Yeah, at the outset, I would like to thank Dr. Abha Nagral for the invitation on a common topic, but which really goes unrecognized, especially in the pediatric population. So I'll just give a bird's eye view of drug-induced liver injury in the next 11 and a half minutes. Let's start with the clinical vignette, and there's the case 1. A 15-year-old girl comes again with headache, vomiting, neck rigidity, and seizures. CSF analysis done, really not classical for TB, but anyway, as happens in our country, you start the child with 4-drug ATT. 5 days later, vomiting increased with onset of encephalopathy. And this is when she comes to the hospital with a bilirubin of 4.2, direct of 3.6, AST 155, ALT 235. And then 4 days later, the bilirubin shoots up to 9, direct of 7, AST, ALT in thousands, ALT more than AST, INR 4.6. And this is a common scenario that we see in Indian children. All labs negative, ultrasound, liver span 9 centimeters, spleen 7 centimeters, no ascites. 12 days later, the child dies of hyperacute liver failure. And if someone says, this child is a small adult, then let's go to a clinical vignette 2. A 2-year, 7-month-old child, girl child, 11 kgs, on 4-drug ATT for 2 months, presents with jaundice 20 days, irritability, altered sleep, grade 3 coma of 15 days duration. And in this case too, antituberculous drugs were given empirically. And this is the child hooked onto the ventilator, to IV fluids, etc. Bilirubin 11.6, which increases to 18, direct 11. AST initially in thousands, but decreases drastically to 178 and 273 ALT. INR more than 3 minutes. All viral markers negative. And the child dies 8 days after admission. And this is a recurring theme we talk in adults as well. Most children who die of antituberculous drug-induced liver injury never required the drugs in the first place. Now, there are scarce reports of drug-induced liver injury throughout the world, but in our Indian series at least, it constitutes to 8.7% of patients with drug-induced liver injury amongst 550 odd patients. In the DILI, and DILI is a drug-induced liver injury network in USA, they constitute about 5.7%. Spain has an excellent drug registry, it constitutes about 4%. So in India, it's pretty high, which prompted us to write this article, and we probably were one of the earliest ones to have written this. Our experience with drug-induced liver injury in children, we worded it a little differently because 2 drugs again and again come out as the most common causes. One is anti-TB drugs and the second one is anticonvulsants. And so when we looked at it, all 16 children who had developed drug-induced hypersensitivity reaction, most probably due to anticonvulsants, all of them survived. But if we have drugs due to anti-TB drugs, and especially if they come with jaundice, then almost 50% of them die. So if you have a child who has a bilirubin of 7, who has acute viral hepatitis, and if you have another child who bilirubin of 7, due to anti-TB drug-induced liver injury, there's 0% mortality in this child, or probably 0.01% mortality in this child. But the mortality here is almost 30 to 40%. So it is a very severe liver injury. The drug-induced liver injury is a very severe problem. And so this is what we noticed in our 36 children that you commonly seen in teens, but then no age is exempt. And again you see these reports in the literature that even neonates sometimes can have drug-induced liver injury. And what are the poor prognostic markers? Anti-TB drugs per se is a poor marker is a marker for poor prognosis. Same with ascites and same with encephalopathy. If the child has skin rashes, then it's a hypersensitivity reaction. I'll talk about it a little later. So these patients actually do well. Now, looking at the drug-induced liver injury data throughout the world, and these are recent data, we had 39 cases, drug-induced liver, DILI network 30 cases, Spain has 36, and WIGBASE is a drug-induced network which is based in Europe. All countries throughout the world send their reports there, and they had about 6,595. Again, across the world, antibiotics are the commonest causes. It's unfortunate that anti-TB drugs are the commonest causes in India, but others includes dapsone and others. In USA, it's minocycline, which is the commonest drug, and that is because adolescents take minocycline for acne, and they develop acute drug-induced liver injury. In Spain, again, there's no augmentin in USA, but augmentin-induced drug-induced liver injury is common in Spain, followed by anti-TB drugs. And again, throughout the world, because Europe as well as USA report most of these cases to be-based. Minocycline, ceftriaxone, etc. are the commonest causes of drug-induced liver injury. Now again, published last year, Journal of Microbiology, children are the most users of antibiotics throughout the world, more than adults. So why is it less common? The answer is probably it may not be less common, it's just that it's underreported. So children are an important class of antibiotic users with specific metabolic characteristics, and clearly more studies need to be done rather than these isolated case reports. Now, I scanned the literature and found that whoever would think that amiodarone, propylthiouracil, montelukast, methotrexate, and fundoparinux, and that is a low molecular weight heparin, all have been known to produce drug-induced liver injury throughout the world. So if you look at case reports, they all been described. But the issue is that they all described one case and two cases, so they are not in form of a network. And again, in Germany, herbals, especially in adolescents, are the commonest cause of drug-induced liver injury in Germany. Now, I, along with Dr. Raul Andrade from Spain, were asked to write this article for drug-induced liver injury due to antimicrobials, CNS agents, that anticonvulsant NSAIDs. And this is a child, again from St. John's, anticonvulsants, and in the previous report we said patients who develop rashes don't develop a problem. But then again, statistics has a strange way of catching up with you. This child took carbamazepine, developed skin rashes, florid Stevens-Johnson syndrome, and died. And this is a post-mortem biopsy showing florid eosinophils. Even though eosinophils per se tells you this patient to do well, but then statistics starts creeping up with you. Now you can divide antiepileptics, which are a common cause of drug-induced liver injury in this country, into two groups. One are the traditional antiepileptics, and look at when they were all manufactured. 1912, much before many of us were born. And you have the second generation. All this first generation are metabolized in the liver. They have drug-drug interactions. You have Stevens-Johnson syndrome, and all of them are known to be hepatotoxic. But then I noticed that less number of children as well as adults are on these drugs. The first group of drugs are excellent drugs. They're cheap, but then clearly there is a problem with drug hepatotoxicity. But in the second generation, lamotrigine, topiramate, and levetiracetam are all excellent drugs, even though there are few reports coming up because people are using it more and more. And so you see a few reports of drug-induced liver injury, although they are excellent drugs. So drug-induced liver injury are rare cause of acute and chronic liver disease in children. They're generally asymptomatic, and that's why you sort of don't suspect it. Acetaminophen or paracetamol is common in the West. Anti-TB drugs are the commonest drug-induced liver injury in this country, and data are sparse in children. Now, children intrinsically are thought to be at low risk for drug-induced liver injury because they're young, they have a metabolic system, they have the absence of comorbidities, differential susceptibility to certain drugs, and again, medicines are given only for a short period of time. Adults take it for a long period of time. But the problem in children is that you give fixed drugs, sometimes you give adult doses. It's based on surface, immaturity of the metabolizing enzymes, especially in smaller children and neonates. And again, generally, I think it's just the lack of awareness of drug-induced liver injury in this country and throughout the world. Now, in pediatric series published recently, 348 children, paracetamol was responsible for 14% and idiosyncratic was 5%. But in India, it's much more. So paracetamol 14%, idiosyncratic 5%. And I'll come to this later because if you compare between adults and children really do worse when they have acute liver failure due to drugs. And I'll come to that slide a little later. So most patients have asymptomatic, but you can span the entire spectrum, including just transaminase, just elevation of enzymes, as you saw in the last case. But they all have a potential to progress to acute drug-induced liver failure. Now, this is the one I was talking about slide, that if you look at in adults, acute drug-induced liver injury in adults contributes to 39% in the West. This is Western data. And the recovery is only in about 70%. But in children, of course, fortunately, is 94% if it is paracetamol, and as we saw in the last case. But if it is a non-paracetamol-induced drug-induced liver injury, the recovery is only 5%. So these drugs are really bad once they develop jaundice and acute liver failure. Now, I have shorter time, but just to rush through the slides, valproate hepatotoxic factors, these are given along with concomitant drugs. The risk factors include age less than 3 years, patients generally are on other drugs. Patients, also those who have developmental delay, develop more of a problem, and mortality is decreasing with rational prescribing of drugs. Now, anticonvulsant enzymes, anti-epileptic drugs, there's varied metabolic rates in neonates, in infants, as well in children. The metabolic rates are faster in children because these half-lives are short, so children tend to get a much larger dose. And because they get a much larger dose, there are more of reactive metabolites formed in these children, and that's one of the reasons why they develop drug-induced liver injury. And again, the amount of valproate that is metabolized in children are much more, almost twofold higher than those in adults, and that's again why they develop significant drug-induced liver injury. Again, as I said, it spans the entire spectrum into acute cholestasis, mixed, and NASH, including fibrosis due to methotrexate. Only a small number of drugs ultimately finally produce fulminant liver failure. And imagine fulminant liver failure is idiosyncratic. There's nothing wrong with the drug per se. It's just that the individual is idiosyncratic, has some metabolic enzymes, or his constitution is such that he develops problem. So how do we diagnose them? You have what is called as RUCAM causality assessment. You really need to do it all extensively that these are not due to viruses. And then all drugs, as I mentioned, have a signature. You take a drug, it comes for a few days later, and then subsides or does not subside. Now, drugs can be classified in intrinsic hepatotoxicity and idiosyncratic hepatotoxicity. Paracetamol is clearly intrinsic. Idiosyncratic is those due to anticonvulsants. And again, idiosyncratic can be divided into two. If you develop skin rashes, it's called hypersensitivity reaction. If you develop no skin reaction, and the classic example is antituberculous drug, it's metabolic hypersensitivity or metabolic hepatotoxicity. Hypersensitivity reaction comes a little earlier, 1 or 2 weeks. Patients take the drug 1 or 2 weeks or 2 or 3 weeks. Metabolic, again, we have seen in anti-TB drugs, it can come within the first 1 month, or it can come even almost towards the 9th month as well, when some patients take this for 9 months. Again, it's not just a problem in India. Look at this series from USA. 20 cases with INH hepatotoxicity. Spontaneous recovery in only about 20%. OLT, orthotopic liver transplant, in 50%, and 20 died waiting for transplant. And what was sad is notably 5 patients with symptoms of hepatitis were initially told not to stop treatment. So again, this is again what we see consistently. Patients have symptoms. Instead of asking them to stop, you say, no, these are the effects of drugs. You are really improving. Continue with the drugs. So we really need to stop drugs at the first moment they have some symptoms. And again, drug-induced liver injury is a real problem in children. Look at INH hepatotoxicity or anti-TB hepatotoxicity. This is again meta-analysis by DILI in children. INH rifampicin 6.9%. And what about adults is only 2.7%. So and again, Indian series from Calcutta in children 7%. So it's really a problem that we need to be aware of. These are the drugs that were manufactured around the World War II. We still don't have good drugs for anti-TB drugs. But if these drugs had to be manufactured now, not one of the drugs would have passed regulatory authorities. But since we do not have any better drugs, we still continue to use these drugs. And we need to use these drugs very carefully. So the lessons, think of drugs at all times. If you don't think about drugs, you will not make the diagnosis. Many of these drugs, we don't have time for it, have track a signature. Phenobarbital, carbamazepine, phenytoin, all have skin rashes. Dapsone has skin rashes. Anti-TB drugs just has no skin rashes. So stop drugs to minimize morbidity and mortality. The issue is that there should be enhanced awareness of drug-induced liver injury of commonly prescribed medications, all commonly prescribed medications, including antibiotics, paracetamol, etc. And you need to minimize the serious hepatotoxicity by identifying them much earlier. So last slide on treatment. The only treatment is really discontinue the drug, the first sign of problems. N-acetylcysteine is now being used for anti-TB DILI. Steroids can be used if there is skin reactions, and L-carnitine for valproate-induced drug-induced liver injury. So thank you very much for your attention.
Amongst the NSAIDs, which would be probably the most or the least hepatotoxic?
The least hepatotoxic, I think, is ibuprofen. That has been drug, and in fact, once we had this, when we reported our patient with ibuprofen, promptly I got a letter from somewhere from Europe Drug Regulatory Authority saying, give us details about your patient. But now, having written this article, you find that ibuprofen, when you compare it even with normal, see, even normal individuals develop raised AST and ALT. So just because somebody develops raised ALT and ALT doesn't mean the drug is responsible. So ibuprofen probably is the least toxic drug, and probably amongst NSAIDs, Sulindac is probably the most hepatotoxic drug. We don't use it here, followed by Voveran or naproxen.
Diclofenac. Yeah, okay.
Diclofenac.
How frequently we should do the liver enzymes for children who are put on ATT?
This question keeps coming again and again. The answer is look at the symptoms. You don't really need to do liver function tests. These function tests are expensive. Now, again, across all guidelines, especially in adults, if you have a patient who has the risk factors. And risk factors mean somebody is obese, somebody has an NFLD, somebody takes alcohol, has got hepatitis B, hepatitis C, all these problems. And children fortunately don't have any of these risk factors. So answer is don't do it routinely. Please go after the symptoms.
I have one.
Malnutrition comes again but again there's no real guidelines that these patients should be. You need to do it early enough, yes, before you start, if at all you want. Even that there is no clear guideline. But we need to follow. Hardly anybody develops problems without symptoms. The patient does have symptoms before they come to you with problems.
Okay, my question is, if somebody is already on an anti-epileptic drug or on anti-tuberculous drugs and then gets viral hepatitis and then gets abnormal liver, you get hepatitis A positive or E positive, should you stop the AED or the ATT?
Ideally, yes. These drugs, once you develop hepatitis, first you need to prove that.
I mean, they have not caused the hepatitis.
Exactly, you're right.
Hepatitis has been caused due to some other reason.
But it's like this. The one, you'll not get a clear yes or no answer. But the issue is like this. If you have raised bilirubin, and bilirubin is really toxic, then you really need to stop these drugs and institute better drugs or non-toxic drugs.
So then you'll stop them for that
but
time being while the viral hepatitis is recovering.
Till they come down. But if the catch is the bilirubin. The catch is bilirubin. If you have bilirubin elevation, then you need to stop it. But again, as I said, if you have raised enzymes, even 1,000, and these patients really require it, and we do it clearly in patients who have HIV. They take these drugs, they have no other problem. The enzymes go up to 1,000, 1,200. Sometimes we don't discontinue the drug. Just per se raised enzymes is not a problem. It's the bilirubin that's the problem. So if you have bilirubin raised, please stop the drug.
Should we change over to the second generation?
We'll need to change over to the second generation.
No, especially in kids who are epileptic, who've been taking their
You're right. I mean,
anti-epileptics
that's a big problem.
for years, and then they develop viral hepatitis. That's when with AKT one is very clear cut that you should stop the rifampicin, INH or pyrazinamide for that period
Recently,
of
my
time.
colleague was telling us that. Go ahead.
Okay. Thank you.
Dr. Harshad, we were taught that once the enzymes go beyond 3-fold or 4-fold, then to stop the medicines. That is what was taught. Now you don't?
Yeah, there's a lot of new knowledge about these raised transaminases. Now, all these are right. We are taught to, and even, for example, even INR. Earlier, you thought any raised INR 2 seconds, you would just stop everything. But we know that INR clearly does not predispose to bleeding risk. It's a good index of liver function. Same thing with transaminases. People are trying to put this out in the open that raised transaminases perhaps are not really significant. So according to the drug-induced liver injury network and definitions, even if you have an AST, ALT which is more than 5 times and don't have symptoms, continue the drug. Don't stop the drug.
Is this with also respect to ATT?
Is there also? In fact, ATT is something I have also, even though it has not come in guidelines, ATT also, yes. 5 times, don't stop the drug. If the patient does not have symptoms, don't stop the drug. If the patient has symptoms, even with 3 times the drug, you need to stop. Even with 2 times, you need to stop. Symptoms are very important.
In children, have you got any studies on nimesulide and hepatotoxicity?
Nimesulide comes again, lots of studies from USA and Europe, nimesulide, that's why it was banned. But my pediatric colleagues tell me that they use nimesulide very often. And in our list of 60 patients, we never.
All syrups are banned.
It's also banned in India now.
Okay. In our series of 60 patients, we just had nimesulide for one patient, drug-induced liver injury in one patient.
Question for you. Have you seen an increased incidence of hepatotoxicity from drugs when we're using drugs like, say, paracetamol in dengue, or conditions where we're treating a fever and there is already hepatotoxicity because of the condition we're treating, and then we're using a drug that's going to add an added insult? So are there any studies, is there any data suggesting that there's going to be a higher incidence of hepatotoxicity?
There's no, when somebody already has and then you give a drug and think this drug is responsible, drug-induced liver injury is a disease of exclusion. You don't have biomarkers. Paracetamol I quoted when we were discussing about dengue because studies have been done to show that it's not the virus that produced the problem, but it was the paracetamol that produced the problem because they had increased adults. But it's clearly difficult because drug-induced liver injury has a particular nature. You have a temporal profile, you have a signature, and if a patient already had a problem, then it's difficult to attribute the drug as a causative agent towards that problem.
Thank you for those very stimulating thoughts. Paracetamol will go on and on. We need to end now.